Hello.
Hello.
Yes, sir. Sir, this is Momita from Planet.
Okay.
Sir, are we good to go now? Shall we
Yeah.
start the session?
Start the session. Yeah. First,
Okay, thank you.
give my brief introduction and start the session. Then hand over to me. I will start.
Okay, sure. Definitely, sir. Hello and welcome to all. This is Momita, assigned moderator from Planet. I wholeheartedly welcome all the delegates across the country, and we are fortunate enough to get supported by the doctors. Thank you all the doctors for taking the time to join us today. I would like to take a minute to introduce our platform Planet. Planet is India's largest live digital CME platforms in India where doctors can generate their medical content. So now I am taking this opportunity to welcome today's master doctor, the eminent speaker, none other than Dr. Rajatsubhra Mukhopadhyay. Sir did MBBS, DCH, MD in Child, PGPN, trained in asthma and allergy from UK, Director in Child Healthcare, Arambagh, Hooghly. So once again, I welcome all of you to this lecture for the topic Fetal Growth Restriction. So before starting the session, I would like to give a brief about today's topic. Fetal growth restriction is defined as an estimated fetal weight less than 10th percentile for gestational age based on prenatal ultrasound evolution. Accurate diagnosis can be made using serial growth charts, daily fetal movements count chart, fetal heart rate monitoring by cardiotocography, and Doppler studies of uterine, middle cerebral arteries, placental ratio. There is no definitive management for FCR except for the correction of maternal factors and timely delivery. Supportive management may help to some extent while waiting for fetal lung maturity. So without any further delay, sir, I would like to hand over the session to you. Kindly proceed with your talk. Over to you, sir.
Okay. Good afternoon, everybody. Today our topic is intrauterine growth restriction. Before going into detail, first let us recapitulate few similar neck-to-neck word or terminology. It will be better to understand them. And the special point that I will emphasize, what will be the practically usable things that you have to keep in mind. This is important. So when you are reading something in book or you are passing in your graduation MBBS or post-graduation DCH, MD, etc., DMD, etc., that is quite different. And when you are coming in actual battlefield, in your practice world, it is completely different. Especially those who are engaged in medical institution, their learning, their teaching, their bedside clinics is again different. And when you are posted in a rural hospital, your understanding, your knowledge, your expertise will be different. But from my side, what I always think and what I always say, that 70% of India is rural India, and this is rising India, and this is mostly based on village and villagers, where neither the tertiary care nor 3-tier nor 2-tier level will facility available. So, being one graduate, MBBS graduate or postgraduate, you have to very clear about this thing, intrauterine growth retardation, why this is very important to know and why this subject is today we are discussing. Intrauterine growth retardation, in other words, you can say intrauterine growth restriction or retardation. Both are IUGR. Both are IUGR, but there are some similar words like SGA, small for gestational age. You have heard this word. You know LBW, low birth weight. You know that is which are preterm baby. Preterm baby. In everywhere there are more or less similarity, some minute differences, and everywhere there are something special to know and keep in mind. Why this terminology is coined? When you are coming to the intrauterine growth retardation, you have to keep in mind that by definition most of the people say when it is below 10 percentile it is called intrauterine growth restriction. No, sir. It is not intrauterine growth retardation. It is SGA, small for gestational age. When it is below 10 percentile, keep in mind it is ASGA. And again you have to know that all IUGR baby may not necessarily be SGA baby. Because there are some examples when there is AGA, but intrauterine growth retardation is there. Especially, they have two classes. One is symmetric, one is asymmetric. When it is mainly determined by the genetic factor or due to some drugs or due to some diseases, then this symmetric type of intrauterine growth retardation occurs. And this is more dangerous because the vulnerability, the potentiality of death, intrauterine fetal death is much more in this case because there are some genetic problem. Maybe there are some genetic problem like Edwards syndrome, trisomy 5, trisomy 18, trisomy 13, like that. But and then some other special diseases also. In some diseases also there is symmetric type of IUGR. But in asymmetric type, where the head is larger in size, where this baby is not so much depressed in respiration or cry, there is ample scope of management, and we can survive those babies. And this is very challenging condition because there the time is the very crucial factor, and this is the strategy of management and availability of your facilities like oxygen, like the warmer, the sucker machine, everything. Even where there is no sucker machine, the D-lead pump, or this type of a mouth-to-mouth sucking, all these things are very important. So now, in this situation, again we are going back to the theoretical part, that what are the predisposing factors for this IUGR. These predisposing factors, I usually divide it in this way, that maternal factor and neonatal factor. And there is another special part, that is the placental factor. That is also both maternal and neonatal both, because placenta is a part of uterus which starts from uterus but ultimately feeds the baby. So in that case also, if there is any disturbance of the feeding or oxygen supply, this IUGR will occur. So this is natural process. So again, we have to think about this part, that what are the drugs, what are the special situations where for the mother where this IUGR can happen. I am naming few of them. You can just listen, or you can remember these things, that tetracycline, cisapride, calcium salts, all these causes there may cause some type of defects in baby. Sulfamethoxazole can cause karmic terror. Chloramphenicol can cause gray baby syndrome. the oxygen, the retinopathy of prematurity, bronchopulmonary dysplasia. Like that, it will come another important medicine, that is erythromycin, can cause the pyloric stenosis. And what are the neonatal morbidities associated with prematurity? There may be respiratory. From the respiratory part, respiratory distress syndrome, that is hyaline membrane disease, bronchopulmonary dysplasia, pneumothorax, pneumomediastinum, interstitial emphysema, congenital pneumonia, apnea, bath asphyxia, you know all these things. And this from the cardiovascular part, etinctactus acidosis, very, very common, hypotension, bradycardia. From the hematologic part, anemia. From the metabolic part, hypoglycemia, very, very common. Hypoglycemia, hypocalcemia, hypomagnesemia, this can also occur. In NEC, in later route, there is a chance of NEC, necrotizing enterocolitis, poor gastrointestinal function, poor motility, so there will be distension of the abdomen. From the central nervous system, there may be intraventricular hemorrhage, periventricular hemorrhage, there may be seizure, ROP, retinopathy of prematurity, or ROP, deafness, hypotonia. In renal, there may be renal tubular acidosis, renal glycosuria, hyponatremia, like that. And infection, that is septicemia, is also there. According to WHO, in preterm, there are two groups. One is moderate preterm, one is late preterm baby. And in this HGA baby also, mild, moderate, and severe. If this is below third percentile, it is severe. If it is below fifth percentile, it is moderate. Why this type of classification is there? Because chance of severity and problem is there. So this classification is there. What are the fetal causes? There may be chromosomal disorder. There may be cytomegalovirus infection, congenital rubella syndrome, congenital syphilis. There may be some congenital anomalies, irradiation from multiple gestation, pancreatic hyperplasia, insulin deficiency. These are the fetal causes that can lead to that. There are the factors associated with IUGR. And what are the placental factors? Tumors, placental separation, twin transmission syndrome, infarction, villus placentitis, decreased surface area, decreased placental weight, cellularity. What are the maternal factors? Toxemia, hypotension, hypoxemia, malnutrition, chronic illness, sickle cell anemia, drugs like alcohol, cigarette, cocaine, narcotics in urban areas, particularly metropolitan area. This abuse, alcohol and cigarette abuse, this is very important part to make our mothers, our ladies aware about these consequences that IUGR can occur. And what are the more late onset possibility from the IUGR? Insulin related problem and this heart related problem. There may be some liver related problem because insulin-like growth factor, insulin production or insulin-like growth factor, insulin receptor, and this IGF factor 1, everything there may be some defect. Pancreatic hyperplasia, there may be pancreatic hyperplasia. So all these things, because of particular this risk, this is very important to know about this IUGR. Now, what we have to practically understand that when the baby is within the mother's womb, we are serially estimating the baby. How? Through the ultrasonograph. From that the birth weight, from the crown rump length, total cell volume, everything we can understand whether the baby is going to be symmetric or asymmetric or there is IUGR or not. And from that, according to the gestational age, we can think about whether we will terminate the baby or not, or we will continue the pregnancy. And for the proper neural growth, what are the things we can give? The folate, proper nutrition, proper hydration, proper oxygen, rest, These are very important. These are very important. And from the serial abdominal Sargat measurement, we can understand whether the baby is growing or not. Maternal weight, serial weight, we can understand that thing. And ultimately, the fetal kick, whether the baby is active or not, from the fetal kick, fetal heart sound, whether there is fetal distress is present or not. Through cardiac tachography, we can see the deceleration, early deceleration, late deceleration, or through this we can understand whether fetal distress is there or not. That's whether distress is from placenta or from pain, from the fetus distress, we can understand through the cardiography. So within the womb, this is the part where when we will do the cesarean section, we will take out the baby for the survival. Now, what will happen? There will be chance of first cry. So whether the baby at all is crying. If there is cry, then sucking and one or two tapping on the soul and just proper positioning and oxygen and the keeping the baby to the warmer. If there is the surrounding is cold, that the temperature, ambient temperature is 36.5 degrees centigrade. But if the baby is cries fast, then again goes to apnea. That we call birth asphyxia. Then it is very important. You have to start again and there. You have to start the cardiopulmonary resuscitation through first chest compression. We have to check that whether then we have to check the pulse rate, the respiratory rate. We have to proper position. We have to extend the throat position, and we have to give the chest compression. If there is no improvement, we have to use the oxygen, and we have to start the cardiac compression also. That is a particular ratio. Usually it is taught in NALS course, Neonatal Advanced Life Support course. But what I am telling again, you have to remember, these all are the consequences of that IUGR, inter-uterine growth restriction. Therefore, I am discussing this part. And apart from that, we have to take the glucose level. There is high chance of glucose hypoglycemia. And if there is hypoglycemia, then and there we have to start the feeding, the GABA feeding or total parenteral feeding or IV fluid if it is necessary as the situation is there. And apart from that, it is important according to the weight of the baby. We can keep the baby in incubator also, and there the total parenteral nutrition we can give. We have to take care about his infection. These are hard infection and electrolyte balance and proper immunization side by side. Everything we have to take care about that. So this is very important. From all these sections, we have to know if there is jaundice later on, then what will be the jaundice level for that newborn baby. If there for the proper perfusion, we have to know what will be the cough level for the measuring the blood pressure, and how we will take the temperature. You have to know that temperature, that part also, what will be the actual temperature level. That part you have to know that in this case. So in that case, pulse oximeter, infusion pump, apnea monitor, everything we have to keep in mind. For the phototherapy, everything we have to keep in mind. One very important piece you all know that in micro drip set, 20 drops in large drops is 1 ml we know, and 60 drops in micro drip set in 1 drop is equal to 4 micro drops. You have to keep in this part for the infusion. And in phototherapy part, we have to care about whether the distance is there, whether proper distance 45 centimeters is maintaining or not, whether the double surface phototherapy is given or single surface phototherapy is given, whether the extra fluid that is required for that heat and this light, that is also given. And the sisters who are working with us, they have to know how skin preparation to be done for pricking, for taking blood, how the capillary blood sample is taken. Cord blood sample may also require intermittent garbage feeding, how it should be given. So this part is also important. Umbilical vein catheterization, sometimes it is important. Umbilical artery line, it is also important. Radial artery cannulation, this we have to know about that thing. Now coming to the endotracheal tube. What will be the internal diameter? What will be the actual size? That depends on the baby. So this is also important part. That how according to the size, what will be the suction catheter length? So there is also one calculation we have to know about. That. So all this part comes under into NICU or neonatal intensive care unit, where this type of treatment is available, and we usually render this type of treatment. But when in outside we are managing this baby, particularly we have to take care about whether oxygen is given properly, whether positioning is done or not, whether the baby breathing or not. If Abgas code is poor, if the baby is not breathing, we have to then and there refer with oxygen, whether temperature is maintaining or not, and after follow-up care, how much fluid we are giving, how much urination is the baby per day baby is there, and if there is some human milk fortified that we can add with the human milk, because for the preterm baby some extra nutrition is important. If it is not available, then by outside syrup, calcium and vitamin D and now DHA, everything you have to supplement from the outside, and within few days you have to supplement iron also, because in the best milk, iron part is also lower, and in this case, iron is very important. For the gut, there are some bacteria, probiotic, prebiotic, that we can use to keep the gut environment friendly, because in this case, gut is also very immature. So all these things are very important for management, from the management part of this IUGR baby, because they are risk. And again, even after their whole management, we have to take that whether there is ischemic hypoxic encephalopathy, we have to arrange for the hypothermia of the brain. If there is not availability, we have to refer the baby to level 2, level 3 care. And if the baby is managed in SNC6 newborn care unit, then the brain ultrasonogram, whether there is interventricular hemorrhage or interventricular edema is there, to pick out that part. And later on, when we are discharging, we have to advise about the examination of the retina, whether the retina presents actually after prematurity on the 28th day of the baby. We have to check that retina for the ROP, and we have to advise about photoacoustic emission also, that is OAE, whether the baby is listening. Because in this case where there is one danger of the hypoxia in the brain, their developmental issue will come, or some certain change may come. So that it can pick up, it will come again his or her developmental part, the late developmental part. So one is preventive section before delivery, the master decision whether we have to continue the pregnancy or not terminate the pregnancy. This part is very important. Looking the ultrasonogram and the history, the whether there is genetic disorder or not. Next part, when the baby is delivering, how we will manage this in that case, what can be the late complication. We have to know from the periphery when we will refer the baby, where we will refer the baby, how we will refer the baby, with proper maintenance of fluid, temperature, everything, and what will be the late consequences of the baby, that the developmental issue, and then later on the management of the diabetes, the blood pressure, etc. So in that cell, I think I have shown one very useful touch to the particular selective medical points, which is important in what particular practicing and day-to-day life, not the theoretical part, what we have actually read in books. This is much important as we all are doctors. Thank you all doctors, my friends. So I'm handing over to again the coordinator. Hello. Hello.
Yes, sir. Thank you so much, sir, for the comprehensive talk, and the presentation was really informative for all of us, sir. Sir, we have received few questions from our participating doctors. With all your permission, can I put them across?
Okay. Sure, but before that, may I know how many participants today is there?
Sir, after this call, we can able to see that, sir. Our team will inform you, sir.
Okay, thanks. Okay, tell me the question.
Yes, sir. Sir, what are the potential long-term outcomes for infants who experience fetal growth restriction?
Already we have discussed what is the potential outcome, the chance of diabetes, chance of heart disease, everything. Just now I have discussed this thing.
Yes, sir. So we can move to the next question, sir. This question we have received from Dr. Lahiri. Have you come across any cases of late onset fetal growth restriction, and how does the management differ from early onset cases?
In early onset cases, when we are suspecting, when we are diagnosing, then we have to take decision. That also I have already discussed. That we have to take decision whether the termination will be pregnancy will be continued or terminate the pregnancy. This is the $1 million question. This will be the $1 million question. That the parents, we have to counsel the parents, we have to counsel the mother that this is your baby is going to be such and such. So if you continue the pregnancy, that will be the consequences. So if consent is there, if a chance is there that before prior the organogenesis and the medical legal part, the particular there is one level that before the 5th week or 5 months, before 5 months, we can terminate. And even if it is needed, medical legal or law, court permission, we can terminate. So in that case, we have to think about this part. And if it is manageable patient, it will, if the baby, we can continue the pregnancy, the baby will deliver, and the pediatrician will, like us, will handle the case.
Thank you so much, sir, for answering the question. Okay, so moving to our next question by Dr. Preeti Jaswal. Are there any preventive measures or strategies that you believe could help reduce the incidence of fetal growth restriction in high-risk populations?
High-risk population, particularly in two parts. One is poor socioeconomic status and very affluent economic status. Why? In poor economic status, there is malnutrition, there is lack of knowledge, there the too early marriage, too frequent pregnancy. This is the problem of illiteracy. And there are multiple, there is chance of several infection, exposure of several viruses. So this is lack of hygiene and illiteracy. So that is very important to prevent, and that is manageable, that is preventable. If proper guide with the local councillor or local personnel, that is political personnel is there, it is possible. When some voluntary organization, NGO, with their help, it is possible. And in another zone, that is affluent society, there the chance of this IUGR because of addiction, this alcohol, because of this smoking, and sometimes some drugs like cocaine, like heroin, like drugs, and irregular their lifestyle, and late marriage. Because of late marriage, if there is chance of obesity, there is PCOD. Number one, there will be the difficulty in pregnancy. Even if there is pregnancy, if there is some problem, there may be chance of this IUGR baby. So in that case also, counseling must be done. Their regular lifestyle must be done, especially from our Bharatiya background, Indian background. We have to always proud about that we are Indian. We have got one invaluable, precious thing from our ancestors, that is yoga. So our guarded lifestyle, our own value, we have to keep with ourselves. So everything we do in high society, middle society, low society, everywhere, if we keep our own values, our own country's values, that is yoga, our diet style, our pranayama, every healthy lifestyle, again, not only this IUGR, from all sorts of diseases, we can prevent ourselves. And our health will be very strong and sound, even without being on allopathic medicine doctor, I am telling, even with a very little demand will be there for any medicine at all.
Thank you so much, sir. So moving to our last question of today's session by Dr. Sahu. Are there any emerging research findings or new techniques in diagnosis or managing fetal growth restriction that you find promising or intriguing?
I couldn't get your question again. Please repeat the question.
Yes, sir. Sure. Are there any emerging research findings or new techniques in diagnosis or managing fetal growth restriction that you find promising?
For diagnosis, the fetal growth restriction, very new research or funding or findings. No, right now I have not seen anything, but I will request to all listeners, all doctors, because you all are respected doctors here, joined with me. And if you have got any new data, you can share with me. And everything, every moment, we all are learners. So there are some new things which is not known to me, but probably some other doctors they know who are much more because I am one part in one section is there. I am expert. They have somebody that they are doing and particular expertise on that part. They know much more about that. So you can share that part. I have got one mail. This is my mail number, and this is my phone number also. It has got WhatsApp also. So everybody can contact with me. You can get it from the climate coordinators.
Thank you very much, sir. Thank you so much for answering all the queries of the doctors. And I would also like to thank all the participating doctors for your continuous participation at our platform. So, sir, with your last comment, sir, we can conclude the session here.
Okay, but I have not, at least after this session, please answer my that question. How many participants are there?
Yeah, sure, sir. Definitely. I will definitely inform my team to let you know, sir.
Thank you so much.
Thank you so much, sir. Take care.